Good evening, everyone. Thank you for joining us. We are coming to you live from the core at the La Encantada Mall. Tonight, we are discussing the advancements in the treatment of heart failure with Michael Arnold from Pima Heart and Vascular. For those of you viewing online, if you have any questions at all, please type them in their comment box. We will be able to see those, and we'll relay those questions to Michael. We do have an in-person audience as well, so you might hear them talking or asking questions. Otherwise, if we have any kind of audio failures or anything like that, please let us know. And otherwise, I will hand this over to him. Great, Michael.
Hello, I'm Michael Arnold with Pima Heart and Vascular. This is my disclosures, clinical work and speaking. The objectives for today primarily going to be to define what heart failure is, first off. It's a term that's used quite often, but we're going to talk about the specific variants of it and how it relates to treatment. Identify the causes of congestive heart failure, and the more common ones and some of the lesser known ones. Describe the symptoms, risks, prevalence, and mortality of heart failure. We're also going to do background on the early management strategies for congestive heart failure, a lot of which was focused on treating symptoms primarily. That was initially with medicine, and then eventually with devices to treat things like sudden cardiac arrest and other problems that occur with congestive heart failure. And the modern age, we've advanced the treatment to look more at the specific mechanisms that cause heart failure and modifying those, both in terms of medicine, which has evolved quite a bit. There's now guidelines based on clinical research and randomized control trials, which tell us what medicines are the best to use. There's also challenges in achieving these optimal medical goals that are set for us. The new and kind of emerging area, which I'm involved with more directly, is the development of device-based treatment for heart failure, beyond just taking pills anymore. So there's new devices out now that help synchronize the heart, they help the heart contract better. There's also devices out that are used to modify the specific disease states that contribute to heart failure and make it worse. So the definition for heart failure, I found this actually alarmingly simple, was heart failure is a chronic progressive condition in which the heart muscle is unable to pump enough blood to meet the body's needs for blood and oxygen, from the American Heart Association. And I felt that there's got to be a more meaningful definition out there for it. But really this is it, and this captures what heart failure is. Heart failure is a syndrome that happens to the body, but it's coupled with symptoms too. There are people who have asymptomatic problems with the heart function, where the heart doesn't squeeze well and they don't have any symptoms, although sometimes I think that's our propensity to pretend we don't have symptoms even when we do. I've had people tell me later how much better they feel once they're treated, some of the asymptomatic people, but it's coupled with basically this basic problem that your heart can't meet the demands of your body through whatever mechanism that is. So we define heart failure in two main terms, two main categories. One is called systolic heart failure, and that refers to the squeezing function of the heart. The ability of the heart to squeeze and pump is reduced. Classically, it used to be called left heart failure. And the marker for this is what's called reduced ejection fraction. That's how much blood is actually pumped out of the heart with each heartbeat. So normal is actually about 50%. So when you get an echocardiogram and your cardiologist tells you the heart function of the EF is at 50%, it doesn't mean your heart function is only at 50% of normal. That actually means you're in the normal range. The heart pumps blood out and it's never totally empty. So we kind of consider 50 to 70 to be the normal ejection fraction range. Once the ejection fraction drops below 50%, people start to have generally some symptoms, specifically with activity and things like that, where you become more short of breath with normal daily activities that wouldn't necessarily have bothered you. Below 40% is considered a reduced ejection fraction, and symptoms can become more noticeable at that point. So heart failure mechanically has to do with when the heart muscle loses its ability to contract and stretches over time. This is a diagram from American Heart Association. This is actually a plastination of real hearts, normal heart versus dilated heart from congestive heart failure. You can see the difference in size there. And on this is taken during an angiogram. On the left is normal heart function. On the right is somebody with reduced ejection fraction. What's interesting about this is that they're both in the same chamber, both in the left ventricle, the catheter. They're both injecting about the same amount of contrast agent into the two. And you can see the difference between what a normal ejection fraction looks like and what a reduced ejection fraction looks like. That will play here. Did that play? Hold on, let me go back. I might have to. Yeah, do we do that with the mouse here, or?
Oh, just a little pat on the bottom.
Oh, okay. I keep trying to hit the play button there. Is it playing?
Are you pushing on your thing?
Yeah.
Oh, it's down here. So
Yeah, I'm just trying to click on the. There we go. Thank you.
Let me see.
Oh, there it popped back up.
There you go.
Okay. So hopefully this one will play here for you guys. No, okay, we'll move on. Hopefully this one's playing. There we go. So this is an echocardiogram showing an ultrasound. Again, a normal heart on the left. You can see the squeeze of the ventricle versus one on the right that's weakened and stretched and dilated. So the other variant of heart failure that we look at is called diastolic heart failure. And as opposed to problem with the heart muscle being able to contract, this has to do more with reduction and relaxation of the heart or stiffening of the walls of the heart. This was historically called right heart failure. And this is actually has a preserved ejection fraction. So the percent of blood ejected with each heartbeat is over 50%. But again, this just means the heart is squeezing normally, but it doesn't necessarily mean the heart's actually functioning normally. Those older definitions of right and left heart failure kind of have to do with the anatomy. On the left side of the heart is in red there. That's a chamber that pumps out to your brain and to the rest of your body, takes freshly oxygenated blood from the lungs and pumps it forward. On the right side of the heart in blue is the old blood, comes back from your head and your arms and your legs and your gut and gets pumped to the lungs to pick up oxygen. So generally speaking, left-sided heart failure with a reduced ejection fraction backs up blood out to the rest of the body. Right-sided failure would tend to build up in the abdomen, the legs, although really clinically we see both in either case. So I go back to that definition from American Heart Association because it really does capture the message. Heart failure basically is a chronic progressive condition and you can't meet the demand. So when you have reduced ejection fraction, the ventricle can't contract and the muscle's weak. So it can't pump strongly enough. With preserved ejection fraction, the heart can't pump properly because it's too stiff and it can't open back up and pump blood moving forward as well. So again, the same definition actually ends up applying. The right-sided heart failure that we used to talk about, sort of assigning diastolic heart failure to right-sided heart failure, most often comes generally from left-sided heart failure where the blood flow is backed up and actually affecting the left atrium, then into the lungs, and then backing up to the heart that way. There are cases of true right heart failure due to pulmonary disease, sleep apnea, things like that, but it's generally pretty rare. And especially when we ask the pulmonologist, they'll always send the patients back over to us and say it's not the lungs, it's the heart. So in most cases, heart failure is ischemic, which is caused by a blockage of an artery that causes the muscle to become weak. The arteries we draw sort of like pipes here and getting blood flow down, but really this is another plastination. If you look at how dense the heart muscle is with vessels, it's just like a tree trunk. And if you cut off a tree trunk, depending on how far back, you lose not just the branches, but all the, not just the limbs, but all the finer branches and twigs and everything on the end. So you lose large territories of muscle when you do have these blockages. The color image there is a nuclear image showing reduced area of blood flow to the heart muscle. If any of you have ever had a nuclear stress test, this is sort of what we look at. So on the top is at rest and looking at the heart in 3 different angles. The isotope soaks into the heart muscle kind of equally everywhere, so we get this nice even glow. On the bottom, is an abnormal. So if you have just a blocked artery that's open but partially occluded, it rests the artery, the heart muscle will light up pretty uniformly, and then when you are stressed, there's diminished blood flow. So you'll see less color filling. If you actually have an old heart attack, these areas stay solid at rest or with activity because there's just no blood flow at all. So we have basically these two buckets for the causes. One is ischemic, and then everything else falls into this category called non-ischemic heart failure, non-ischemic cardiomyopathy, dilated cardiomyopathy, which basically means it's not due to a blocked artery or reduced blood flow to the heart muscle. The non-ischemic heart failure causes can be valve disease, uncontrolled high blood pressure is a common cause. There's infections like myocarditis, drug use, alcoholism, kind of a smattering of other defined causes here and there. Unfortunately, up to 50% of these are actually considered idiopathic, which means we don't necessarily know the original cause for the patient who have had an episode of heart failure and reduced heart function. But functionally, it ends up being pretty similar. So on the top row, you can see normal heart muscle cells, and then the damage to heart muscle cells after a heart attack. On the bottom are various other conditions that would fall into that non-ischemic category, including inherited conditions or viral infections that affect the heart muscle. And if you look sort of just grossly at the two, you can see that comparing the top and the bottom, you can see that both do a similar amount of damage. It's just different ways that damage occurs. So this is looking at normal heart muscle on the left side of the screen. In the middle would be a non-ischemic pattern where there's just infiltration or areas of scar kind of smatter throughout, and in ischemic where there's a specific defined patch of scar we can see. So on the stress test, we can see a large area drop out in a specific pattern that reflects where that heart muscle is dead there. But functionally, the two, heart failure with a reduced ejection fraction and heart failure with a preserved ejection fraction, have a lot of overlap, and a lot of the causes are actually similar in both cases. Smoking can cause heart attacks, increases pulmonary disease, kidney dysfunction can contribute to both, obesity, age. An interesting area that's being looked at more and more is sleep apnea and the role in heart failure. Not only does sleep apnea seem like it plays a significant determinant in how well people with heart failure do, but there's also the potential that sleep apnea can contribute to worsening heart failure or advancing people from diastolic heart failure to systolic heart failure. Interestingly, 50 to 65%, depending on the studies. I did see one study at a VA that was actually up in the 80s percent of patients with heart failure also have sleep apnea of one kind or another. And sleep apnea as a condition increases your risk of eventually developing congestive heart failure by 140%. So a lot of that has to do with the mechanisms of that. I tell patients that sleep apnea is about as healthy for you as having somebody smother you intermittently all night with a pillow, because that's basically what your body's going through. Your oxygen supply drops dramatically. So not only are you not getting oxygen to your brain, but to your heart muscle. Your heart has to beat faster. It sends hormonal responses. The pressure in your lungs goes up. The sympathetic nervous system, which is your fight or flight response, is activated. And that's happening continuously throughout the night when you're actually supposed to be resting. So your body doesn't get to restore itself. So there's been more and more looking at not only obstructive sleep apnea, which is the more common variant people have, where the airway collapses at night, contributing to some fluid overload and congestive heart failure, but also contributing to central sleep apnea, which worsens heart failure as well. So regardless of what the cause specifically is, the mechanisms are the same. The heart starts to enlarge initially because it's being stretched, and it has to contract more firmly. So if you think of like a rubber band that's pulled and stretched, at some point as you pull that rubber band a little bit further, you get a little more recoil force on it. That's called the Frank-Starling law. Over time, if you take a rubber band and you stretch it too much, it loses that ability to bounce back. So the heart has to pump harder, has to contract stronger, it develops more muscle mass, which makes it get bigger, but that doesn't necessarily help the problem. The heart tries to pump faster to increase its output. All of these are mechanisms to try to compensate for the problems with blood flow. And the rest of your body tries to compensate as well. So your blood vessels start to narrow to try to keep the pressure up to your vital organs. Blood gets diverted away from your fingers and your toes and less important tissue to keep your brain and your kidneys perfused. We used to classically refer to heart failure as CHF, or congestive heart failure, because of the congestion it creates in the body tissue, but swelling in the feet and the ankles, and that can move upwards on the body. The kidney's ability to get rid of sodium in water is impaired, so you begin to retain sodium and you retain water, which increases the fluid and the edema, which then increases the workload on the heart muscle, which is already not working well. So I love this kind of old low-res diagram of heart failure, but this basically was it and how it presents. These are the heart failure symptoms primarily: lung congestion, swollen ankles, fluid retention from the kidneys, and enlargement of the heart muscle. And we classify heart failure based on their symptoms. So some people have absolutely no symptoms, and we call that class 1 heart failure, which isn't something we rarely ever see. Class 2, people have some symptoms, but they can get by with their normal activities. They have to rest at times. Class 3, people have worsening. When you get to class 4, basically, even without activity, you're short of breath and you can have chest pain even. So initially, treating heart failure just focused on treating those symptoms. The original drugs to treat congestive heart failure, going back for a long, long time, were basically just diuretics to get fluid off, and digitalis, which has been out, this is a foxglove, it's been out since the medieval times, to help the heart pump better. In the end of the 80s and beginning of the 90s, we started looking at newer therapies to improve heart failure treatment, but primarily everything was directed at treating symptoms. So you had lung congestion, use a diuretic. You had fluid in your feet, use a diuretic. We could use digoxin to help the heart pump a little better. The kidneys weren't getting rid of fluid, we used a diuretic. We didn't have a lot of specific treatments aimed at heart failure, just treating the symptoms. And unfortunately, with it being a progressive and chronic condition, over time the symptoms start to outpace the treatment, and chronically people would just get worse, and we would just keep upping their meds and not really get much better. And heart failure, unfortunately, has a very high mortality. 1 in 5 Americans can get it. They estimate 6 million people in America have heart failure, and it's expected to go up significantly over the next 15 to 20 years. 50% of people who are diagnosed with heart failure will die within 5 years of the diagnosis, unfortunately. And for those who have advanced heart failure, very severe symptoms, or a severely reduced ejection fraction, the likelihood of them surviving more than 1 year can be up to less than 1 year, is actually 90%. Patients who are diabetic have a much higher mortality with diabetes. Men, with heart failure, men have a higher death rate than women, and it's a higher rate in blacks and whites and Hispanics. And if we look at the map in terms of heart failure death rates, there is sort of a heart failure belt there, you can see, and unfortunately it sort of matches the stroke belt and the heart attack belt and other things in the country where the incidence of these cardiovascular problems are quite high. When we look at Arizona in particular, we can see in Pima County, the hospitalizations for heart failure aren't that bad, which is encouraging. Unfortunately, the deaths from heart failure in Pima County are a bit higher, which is a little unsettling that our hospitalization rates are pretty low, but our death rates are high, as opposed to Maricopa County, where their hospitalization rates are higher, but their death rates are lower. A lot of that has to do with the population in the area and other factors, but it's a considerable cause of mortality here. And patients with congestive heart failure often die from what's called sudden cardiac death. When people have early heart failure, that's most likely to be the cause of death for them, is sudden cardiac arrest, where the heart has a rapid, life-threatening arrhythmia that can't pump blood effectively, and generally would need defibrillation in order to stop the arrhythmia and for the person to survive. As heart failure advances, the other causes of death, or what we call sort of pump failure death from congestive heart failure, go up. The risk of sudden cardiac arrest is lower because as the condition worsens, there's other things that are more likely to be the cause of death. So sudden cardiac arrest is actually something that was treatable with a defibrillator. Dr. Michel Morawski in the 80s had worked on people who had cardiac arrest from other conditions and survived it, which was a fairly low number. But if you had a cardiac arrest due to an arrhythmia that they could document and you survived, they would go through this procedure of implanting a defibrillator, which was quite large and required an open heart procedure. Initially, it wasn't well looked upon by people because there was a low benefit to it. Not a lot of people survived to begin with. So people thought to themselves, well, what if we actually took a defibrillator and used that in the population of people who have sudden cardiac death, the highest rate, which is people with congestive heart failure, and use that sort of as primary prevention and did it preemptively. So that was the start of the first trials to look at using defibrillators to treat sudden cardiac death to help keep heart failure patients alive longer. So there's MADE-IT 1 and 2. Both of these basically are pretty influential trials. On the graph there to the right, this is looking at your likelihood of surviving out to 4 years. The dotted line at the top is the portion of the study that had a defibrillator plus regular medical therapy for heart failure. The line on the bottom were patients who had regular medical therapy for heart failure but didn't have a defibrillator. And you can see where that line really diverges out over time. So this is what helped establish the benefit of defibrillators in preventing sudden cardiac death as a primary prevention tool for patients with congestive heart failure. So now we use defibrillators all the time. They work pretty effectively. They can be implanted in the vein. There's some that go under the skin. They're able to detect an abnormal heart rhythm that would be lethal otherwise. And within 30 seconds, the device can charge and shock, and in most cases terminate the arrhythmia on the first shot. The important thing when talking to patients about defibrillators, especially our patients with congestive heart failure, is that defibrillator itself is a tool to help prevent you from dying suddenly. A defibrillator does not, unfortunately, help you feel any better or treat your congestive heart failure. It's not going to do anything to reverse it specifically on its own. It's just there to monitor for an arrhythmia and treat it. It's similar to an AED you would find in the mall here. Walking around, it's just with you all the time. So they started advancing heart failure monitoring, and defibrillators got more monitors and things put in them to look at patients' fluid balance so we could try to get on top of their symptoms and treat it. There's pressure sensors, a device called cardiomems they can put in the pulmonary artery in the lungs to pick up the pressure and the fluid load to try to get us on ahead of schedule in treating a patient when they start to build up fluid before they're even developing symptoms necessarily. One question we get asked a lot are what patients can do on their own to help once they've been diagnosed with congestive heart failure. Exercise comes up a lot. There's been a lot of trials that show that exercise is safe if you do it reasonably. Unfortunately, there's no way to exercise your heart out of congestive heart failure. You can't go and work out and help the heart muscle get stronger. It doesn't work that way. And often I tell patients, unfortunately, that if you overdo it, you're more likely to set yourself back as opposed to make any gains. Dietary changes are another one that are big, and people always ask what they can do to change their diet so that their congestive heart failure gets better. We generally tell patients to restrict their sodium, their salt intake, and try, in some cases, to restrict your fluid intake, because the more salt you take in and the more fluid you take in, the more your body retains that fluid and can make your fluid overload worse. But there's been no specific diet in any trial that's been shown to reverse or improve congestive heart failure once it's actually set in. So, yeah, unfortunately, it'd be nice if it's like, oh, it's simple, just start eating beans and fish and you won't have congestive heart failure anymore, but it's not that way. Once it's set in, and part of this actually has to do with the compensation that the body goes through, because not only are your blood vessels tightening up in these acute changes to try to keep your oxygen level balanced, but over time there's enzymes that are released and hormones released by the body where it starts to regulate your salt and your fluid balance and how the muscles and things start to contract. So this is where we get more in understanding in the more modern age the mechanisms of congestive heart failure. And it turns out it's a lot more than just the heart's big and not squeezing well and you get fluid in your ankles. There's a whole slew, and it affects fairly well every body system to some degree or another. You get hormonal input from the kidneys, from the adrenal glands, the brain, the vessel walls themselves are actually capable of sending out hormones to try to regulate, and that starts to remodel the heart tissue. And once you start this remodeling, we call it a negative remodeling process. Once you start this negative remodeling, the heart can't work as well, and then it becomes sort of a vicious cycle. And this initially, when I was first starting out and looking at cardiology and heart failure in particular, and people would talk about genetic expression in heart failure, and my eyes would glaze over and roll back in my head because I felt like it's not not anything that matters to me clinically. But it really does, unfortunately, when you look at these genes. So these genes encode how the proteins on the heart muscle work and how the muscle actually is able to contract. So in a normal heart with healthy gene expression, these gates work properly and calcium moves in and out. When you have congestive heart failure, as the gene expression changes, the heart physically can't contract properly anymore because it loses the ability of these key proteins to function. So that actually becomes a much more important piece of the big picture and what happens in heart failure than just specifically what your fluid level is on a monitor. So it was nice and simple when we just treated you with diuretics. And if you had more water on you, we gave you more diuretics. And if you were a little dried out and your blood pressure was low, we give you less diuretics. But that doesn't really address all these other mechanisms. So this next slide is intentionally awful and busy because this is actually all the mechanisms clinically that are in play when somebody has congestive heart failure and all the enzymatic pathways that we're looking at trying to block and treat. So modern medical therapy is looking specifically at treating all these targets. And we have what's called guideline-directed medical therapy. Guideline-directed meaning that there were randomized control trials, generally multiple trials that have shown the patients did better and survived longer on specific medicines as opposed to others and at specific doses. So generally, when we talk about guideline-directed medical therapy, that's sort of our new standard. Diuretics, actually, digoxin, the things we used to use, calcium channel blockers, actually haven't ever shown any mortality benefit. You're not likely to live any longer, which matches also what we saw clinically with people when we would treat with those. They would just get worse gradually over time and pass away. And sometimes you could slow that progression to some extent, but you couldn't ever stop the train. These medications now, the new slew of medicines we have actually have a much better effect. Some of the newer agents like Entresto, which is an angiotensin receptor blocker, plus a new classification of drug called a neprilysin inhibitor, reduces your fluid retention, and that controls some of the enzymes that are released when you have a flare-up of congestive heart failure. So they looked at Entresto, which has this combined effect with an ACE inhibitor, which used to be our old gold standard, and the graph here is showing the probability of a heart failure event, and the red line are patients who are on Entresto. So you can see that over time, with Entresto, the risk of you having death or hospitalization from heart failure is actually lower on Entresto than a classic ACE inhibitor. So now the American Heart Association guidelines actually say if a patient's on an ACE inhibitor or an angiotensin receptor blocker, and they have class 2 or 3 heart failure, they should be switched over to Entresto as opposed to just left on whatever medicine they've been on in that other category for a number of years. There's even newer agents out now. These are called SGLT2 inhibitors, which are actually medicines that were used to treat diabetes initially. And because of issues with some diabetic medications and cardiac complications in diabetic medicines, diabetic medicine trials were required to look specifically at how new drugs did in terms of heart effects. And for this class of drugs, it was sort of a serendipitous finding that people's heart function actually got better. The heart failure was less when they were on this drug than the group that wasn't on this drug, which was the opposite of what was expected. And other trials have been done to look at that same effect even in patients without diabetes. These help your body shift how it handles glucose and sodium in the urine. So it's those are excreted from the kidneys and often they're reabsorbed back. These two medications inhibit the reabsorption of glucose and sodium. So if the glucose and the sodium stay in your urine, the fluid follows them and it doesn't come back in your body to cause you to retain fluid. So they can actually help you lose weight. They have good effects on the fight or flight system, the sympathetic nervous system. And this effect looks like it's related to all the drugs in this class, basically. We can see that placebo versus any one of the drugs, the two that are available in the US are Jardiance and Forxiga, but outcomes were better for patients on a drug as opposed to being off of it. The same actually was true with Entresto, where Entresto showed a specific improvement in heart failure mortality. What was interesting with Entresto was that not only did it help reduce heart failure and other problems, but it actually reduced sudden cardiac death, which we kind of consider to be an electrical phenomenon, despite how people were doing in terms of their heart failure otherwise, which is a unique finding from the Paradigm HF study. And interestingly enough, there's another trial called DAPA-HF, which looked at the same group we were talking about earlier, the SGLT2 inhibitors, and found that they had the same effect too, where people had less arrhythmias and less cardiac death on these medications. So again, it sort of plays into the whole enzyme pathway affecting multiple ways in how the heart works, your sympathetic nervous system, and all these things. There's even newer drugs out now that have specific targets. So Corlinor is one we use for people who have high heart rates but low blood pressure and can't tolerate a higher dose of a beta blocker. So we want to slow the heart rate down. Congestive heart failure, heart rate of less than 70 is ideal. So the heart's not racing or working too hard. But lots of times when we try to slow that down, we lower people's blood pressures. Corlinor doesn't have an effect on blood pressure, but just heart rate if you're in normal rhythm. There's a newer drug out called Vercuvo, which is actually the first of its kind of similar to drugs we use IV in the hospital to help the heart muscle contract. And that's indicated for patients who had a recent heart failure hospitalization. So I go back to that super busy slide with all the pathways. And really, you know, this is the kind of thing I'd said before I would look at and my eyes would just glaze over. But in any given day, I'm working with all of these drugs in any given patient in lots of cases and just prescribing, you know, multiple medicines. And I tell people, instead of looking at this diagram, which is awful and makes my head hurt, I try to think of the heart like a castle. It's got a lot of gates all the way around it, basically. So the more mechanisms we know about, every time we find a new one, that's a new gate that we have to guard. It means there's another medicine we need to use to try to treat that specific mechanism. And the studies are looking now in particular, not only just are people on a medicine like a beta blocker, are you on a medicine like Entresto, but people who are on combinations of medicines, what would be considered, you know, comprehensive medical management. And in this graph in particular shows a 6-year survival benefit from being on comprehensive management, meaning all of the right drugs that we need to have you on for heart failure management. And not only using that same gate analogy, do we have a castle with a lot of gates around it, but with all these gates, we want as many guards as possible at each gate. So not just being on, you know, a you know, tiny half of a tablet of carvedilol or a half of a tablet of Entresto that's going to do the trick. We want to try to get people to the highest dose they can tolerate on any of these medications. So the higher the dose, the more enzymes are blocked and the better people do.
But this 6.5 years, what sort of quality of life do you
I can't answer that directly from that study overall. But actually it does come up here when we talk about medication, because that is an issue with medicine and the quality of life, and how people feel on the medications in particular. And often I'll just kind of get to the fact that sometimes it's hard to suss out whether you feel poorly because of a specific medicine you're taking or whether you feel poorly because you have congestive heart failure. And if it's a problem with the medicine making you feel poorly, usually you'll get over that over time as you're on the medicine, your body gets used to it. If it's congestive heart failure and we stop a medicine that would be helpful, it's not going to get better. So, but it does get tricky to tell, and that does come up quite a bit. But you know, the studies continue to show that people do better on higher doses of these drugs. So it's not just being on the drug, but actually it's dose specific. This is looking at carvedilol, Coreg, which is a very common heart failure drug, and the difference in survival based on how high of a dose of Coreg you can take. But often for people, that's kind of beyond their control. You know, this is looking at in an outpatient setting, a percent of patients who kind of should be on a drug, patients who aren't eligible because of, you know, one issue or another, kidney dysfunction or those sorts of issues are in blue. The red are patients who are on one of those medicines that are considered optimal therapy. And the green are the percentage of patients who should be on the medicines and aren't. And then this is looking at how long it took to actually get people on the optimum doses of those medicines. So this is looking at over a year and still pretty poor numbers in terms of the percent of people who actually are on those doses. So it's difficult to get people on optimal guideline therapy. There's side effects with low blood pressure, kidney failure, and other problems. Newer drugs are expensive. They're not generic. So that's a big issue for a lot of people, unfortunately. And less than 18% of patients, I found this was just blew me away, this number, but less than 18% of patients are actually on optimal medical therapy at 90 days after their hospital discharge for congestive heart failure. meaning kind of a combination of either not on the right agents or not on the right doses or both. So less than 18% of people that we think we're treating with these medicines that do help them get better are actually able to take them because of some of the reasons that we mentioned before. So, you know, we look at the medicine treatment for heart failure, and it's gotten a lot better. It's you know, magic in a bottle. I was saying here, you know, we've seen such an improvement in heart function. People's ejection fractions can get better in lots of cases. People have less cardiac arrest and arrhythmias with these medications. There's really been a significant improvement. And the one thing that, you know, hasn't changed, unfortunately, is the other causes of death down the road for heart failure. And you know, we look at the defibrillator, and that was just an initial attempt to get people alive and get them through the first year. But the question has been, what do we do going beyond that, and helping people feel better and their quality of life get better? So sort of an interesting concept came up in the early 2000s, looking at using devices to actually treat congestive heart failure. In particular, this looked at patients who have what's called a left bundle branch block, where there's a significant electrical delay between the right and the left side of the heart. So the right side beats first, then the left. So I tell people that's like taking billows in a fireplace and going right arm, left arm, right arm, left arm. It's not going to pump as well as pumping both in sync. So initially as a pacemaker, but in a lot of cases, because these patients have low ejection fractions, they get the variant that paces and defibrillates them. They have what's called a biventricular defibrillator or biventricular pacemaker. Actually, all of this has to do with the pacing side more than the defibrillation specifically. The defibrillation is just, the defibrillator part is just there as a backup. But a wire is advanced through a vein to the side of the left ventricle. We put a wire in the right ventricle, and then the computer in the device, and looking at the EKG and sometimes looking at the echo, we try to figure out the timing to get the heart muscle to contract in sync with itself. And in most cases, people will respond. Up to 70% of people will feel better and have an improvement in their ejection fraction just by synchronizing the two chambers. So this trial made it CRT, it was called, which was moving forward from the initial ICD trials, looked at if you had people on optimal medical therapy at an ICD or people on optimal medical therapy at an ICD with this left ventricular pacing, it's called cardiac resynchronization or CRT, how did they do? And the percent of people who survived, the red line are people who had the biventricular device. So even with a defibrillator, the survival was much better going 4 years out with this resynchronization device as opposed to just a defibrillator alone. So, you know, I kind of joked that now we're looking at magic in a can instead of a bottle with the devices. There's more and more clinical trials that show that when patients have a left bundle branch block, the important treatment actually isn't necessarily medicine. Medicine has an important role in treating the symptoms of heart failure and working on some of the enzymatic things that are happening. But patients generally don't respond as well to medicine alone as they do to improving the timing of the heart function with this extra wire. And these studies actually show that there's a sort of a critical window too, where the earlier we do this, the better people will do. And you can't miss that window by spending too much time working on adjusting medicines for a condition that you can't fix. You can't fix a left bundle branch block with a medicine. It's just a timing issue in the heart muscle. So that really helped us kind of evolve the concept of how are we treating heart failure. And before, we used to have monitors and we'd watch people kind of just gradually get sicker, unfortunately. And the defibrillator was there to stop them from dying prematurely, but we didn't have anything to help them actually get better. And cardiac resynchronization was one of the first times we had a device that could actually help somebody with congestive heart failure get better and the heart function improve and their symptoms get better. So it's really become a big evolution in how we look at it. The hurdle to that was that the percent of patients that qualified for this device is relatively low. So this is looking at patients with a wide QRS, which is the finding we see that tells us the timing is off. So that's on the EKG. Instead of a narrow, skinny contraction, it's a wide, erratic contraction in the ventricle. The left bundle branch block, that actually is only 21% of the total population of patients with heart failure with reduced ejection fraction in this study. So the remaining 79% have kind of a typical normal EKG, like hopefully you or I all have, where the heart function is narrow and the timing is pretty consistent between the two chambers, but it's still not pumping well. So for a long time, we had this great device that could help people get much better if they had a left bundle branch block. And if they didn't, we didn't have anything. It was just a letdown to say, We can give you a defibrillator, which won't help you get better, but we can't fix you. It's too bad you don't have a left bundle branch block, which you don't really want somebody to have. But for our purposes, it'd be like we can fix that. So there's been a big evolution coming up. This kind of proved to us that devices work in helping heart failure. There's a new device out now. It's called cardiac contractility modulation that applies to that other portion of the pie that isn't a candidate for resynchronization, where the timing between the two chambers is normal. Often we actually end up putting that device in alongside a defibrillator. These patients already have a defibrillator in, so we put it in on the other side. I joked that one of the most common two questions I get for patients with heart failure is, why is my doctor having me on so many medicines, and why do I have so many devices? But especially as we're getting more into the device side, there's more and more things we can do to help and fix it. And arguably, we might get to a point where some of these devices might make it so that you don't need a defibrillator anymore if the heart function gets better. So this actually works kind of similar to the TENS unit and things like that, where it looks at the muscle contraction and it delivers an impulse at the end of the contraction to help the muscle hold firm for just milliseconds, thousandths of a second, but enough time to help the contraction in particular. So we see the force of the heartbeat go up immediately when you turn therapy on. And here's the actual EKG from a patient where you can see it being delivered there. And the therapy itself, locally, as soon as we turn the device on, we see a change in how the heart muscle contracts. Over time, it actually starts to affect gene expression and how the tissue's behaving. And then overall, not only just the chamber where the device is and the tissue where it's implanted gets better, but the whole heart muscle overall improves to some extent. So those genes that we were looking at earlier do become important, and they're actually reversible. Those we can get the body to correct and start fixing. So we get this remodeling effect going on where you get normal gene expression. So the oxygen consumption, quality of life, mortality, heart failure hospitalizations all can improve just by fixing this mechanically with a device. So here's some patients where we've had different devices that have helped. And you see beforehand, the heart's not contracting that well, and then afterwards we get a significant improvement in how the heart muscle is able to squeeze. This one here at the end is my favorite. You can see a real big difference there. But again, it's with the gene expression, not just the local effect of helping the heart muscle contract, but actually overall how the tissue behaves. So there's more and more devices out now that not just treat how the heart muscle contracts and the genes like resynchronization and cardiac contractility, but also the other factors that contribute to worsening sleep apnea. There's devices out now that are similar to pacemakers to treat sleep apnea. One that we implant is called a Remedy device, which is basically like a pacemaker that goes to the diaphragm to stimulate the diaphragm to contract to help you breathe while you're sleeping. For patients who can't take a beta blocker pill, and for overall benefit, there's a device called Barrow Stem, which actually stimulates the sympathetic and the parasympathetic nervous system, which calms the heart muscle down and helps reduce the heart rate and blood pressure and things like that. So more and more we're finding these devices work to treat congestive heart failure. Medicine works too in many cases, but in many cases it doesn't, or people can't be on it or can't be on the ideal levels of medicine. So really we have a framework now where we have medicine we can get people started on. Sometimes with medicine, we've had a lot of people recently between COVID and other things have congestive heart failure. We put them on a medicine and the injection fraction improves and their symptoms improve. But there's patients where that doesn't happen in any kind of timely way. And between all these options now, we're getting to the point where we have devices that, regardless of what your ejection fraction is or what the EKG shows, or whether you can take a pill or you can't take a pill or tolerate a specific pill, the device is there and working to help your heart get better. And really, the data shows these devices improve not only quality of life, but people report that they feel better, but actual functional tests like how far can you walk in 6 minutes, your oxygen consumption on a treadmill, measurable effects can be improved. And the other interesting thing we see with these devices is that this study looked in particular at patients who we're on the better side of congestive heart failure, so an ejection fraction between 35 and 45%, and then looking at kind of patients overall with an ejection fraction less than 35%. And we look at the oxygen consumption, the quality of life, the hall walk, all those things. The earlier we treated patients, the better. So instead of waiting for somebody to get an ejection fraction that was down in the 30s or 20s, getting on it sooner actually helped them improve, which I tell people it's like a leak in your roof, right? The sooner you fix it, the better you're going to do. There's no point in saying, okay, I'll just wait till it gets really bad to fix it. So, I mean, really that bears out with congestive heart failure and these things as well. So, the prior spectrum was we just kind of from a device standpoint had devices to kind of watch people and see how they did. We had a little segment where we could actually help them get a little bit better. But now that's widening out to the point where we have a broad spectrum of patients that we can help with devices to actually get better in congestive heart failure. And device isn't for everybody, but medicine isn't, nothing is. And I envision that in the future, as the device technology and things continue to improve, we'll find more and more of a blending of the two for patients. And ideally get to a point where heart failure is a reversible diagnosis and it's not a progressive march towards kind of fatality, which unfortunately is lots of times. So,
A lot of these therapies really expensive though, as far as machines and like pacemakers, insurance covers some of that stuff.
Yeah. The newer ones, and this is sort of typical for insurance coverage, is they have prior authorization processes and things where you really have to show documentation. Often what comes up with the devices is we have to demonstrate that medicine-wise we've kind of exhausted all the options for medicine for patients, which I don't necessarily disagree with. I just hate, I tell people it's kind of the notion of like somebody's drowning off of a dock. Do you wait for them to prove they can't swim before you throw them a life preserver? Like how long do you have to wait? With medicine, and especially when we look at things like the resynchronization where we know medicine's not going to help them get better, and there's kind of a key timing window where the earlier we do it, the better they'll do. But right now, almost all these things are covered by insurance companies. We just have to, pacemakers so much nowadays and defibrillators, really, we don't necessarily have to prove that often that, we submit paperwork and things, but it's very rare to have to do, a phone call peer-to-peer with a cardiologist to say, here's why I'm putting this in this patient. And then, they've pepper us with questions. Why did you do this? Why did you do that? That's really not been the case anymore. And I expect that over time, with BiV defibrillators and pacemakers, that's come to be the case more or less now too. They want to know they're on medicine. We'll get phone calls back if a patient isn't on any medicine. And often, if I'm seeing them from another cardiologist and they come in and they're just on 3.125 milligrams of carvedilol, which is like the lowest dose it comes in, and that's it, I have to go digging through the chart because I know I'm the one they're going to call and ask, well, why is the patient only on this? And often it's because they have kidney dysfunction, they've tried other medicines, their blood pressure got too low, they had a reaction one way or another. But we have to basically prove that we've at least tried medical management. We use the term kind of maximally tolerated doses of guideline-directed therapy, meaning we've tried everything we can medicine-wise within reason, and they haven't improved, so then we're moving to a device. And in most cases, they'll be approved.
It's the last-ditch effort, sort of.
Well, right, and that's my hope is that as this concept kind of evolves, we get away from that notion of like waiting until we've exhausted every possible pill before we start using devices if we know they work. Yeah. Right. And it's really interesting because with the defibrillators, we use biventricular defibrillators most often, more so than biventricular pacemakers alone. And that's because of the ejection fraction. People have an ejection fraction less than 35%. They're at risk of cardiac arrest, so we use a defibrillator. There's a lot of patients we put a biventricular defibrillator in, and through the pacing part of it, their ejection fraction goes back to normal. And then they don't actually need a defibrillator technically. There is some data that says if you ever had heart failure, higher risk for cardiac arrest than someone who never had heart failure. But arguably, it's reversed, and the likelihood of them having sudden cardiac death is extremely low. But we don't go and take that out at that point and just put in a pacemaker. But we haven't historically put in a pacemaker and just given somebody, it's called a life vest, which is a wearable defibrillator, a temporary defibrillator, while we wait and see if they get better either. But, hopefully as we start looking at in the future and intervening sooner with these devices, we can get to that point where maybe the defibrillator part is what's held off to the very end when we've said we've done everything we can. There's not anything else we can do. We're just going to put this in so you don't die on your kitchen floor unexpectedly. And the other devices are the things that we are using to actually treat people's congestive heart failure and get on those earlier and help them get better. So, well, thank you very much. Appreciate it. And
Anita, do you have any other questions before we give ourselves up on the live stream?
Well, like, is there an age that this normally starts happening?
yes, and unfortunately it's at 40, the risk starts going up, but let me go back here to the incidence, sorry. All these drugs. Yeah, so here's the rate, the breakdown with ages. And in particular, it doesn't necessarily talk about onset in as much as it's looking at the mortality, the risk of death associated with age. Obviously, the older you are at the onset of congestive heart failure, the more likely you are to succumb to it eventually, unfortunately.
Well, like my sister was just diagnosed with COPD a lot of times. Yeah.
Mm-hmm.
And I saw that that's a factor. Talking about it.
Yeah, it can be, and especially diastolic heart failure is a lot of that, where the ejection fraction is still strong, the heart's still pumping. That can be kind of more that classic right heart failure, where the hang up is the heart trying to pump into the lungs. The difficulty is getting blood out of the heart and into the lungs to pick up oxygen. From that point on, from the lungs forward, the flow is actually pretty good, but the lungs are stiff and the heart's got to work hard. So we see the pressures go up. But clinically, you can develop the same sorts of things, the same congestive heart failure symptoms, swelling in the legs and all those kinds of things. Here's sorry, we're looking at the two, and we know left heart failure often can cause right heart failure. Right heart failure in and of itself has been trickier to treat. There isn't as much guideline-directed medicine to use for diastolic failure. That cardiac contractility device, the one that kind of strengthens the heart muscle contraction and does have some genetic expression changes, they're actually doing a trial right now on people who have normal ejection fractions but heart failure symptoms to see if the device helps. And we were at a heart rhythm meeting this summer, and I said, I think really in that case, we're looking at it more as like a gene modulation therapy than really contractility modulation. If you're saying the heart muscle contracts okay in this person, but they're going through the same genetic expression problems and downregulating of essential proteins and all these things and heart failure, and this device fixes that, we're actually using it more for the remodeling on the gene side than the local muscle contraction in particular. But it's promising, and when they look at the overlap between the two, the interesting thing is that, and I didn't put it into the slide because I didn't want to, I already have so many, but there's a lot of overlap between diastolic heart failure and systolic heart failure. People have a diastolic heart failure initially, or people have systolic heart failure often have diastolic heart failure too. So diastolic heart failure has been a little bit of a tricky conundrum to manage, and especially in COPD, because it's so hard to tease out. Is it fluid overload that's causing you to be short of breath? Is it a problem with the lung tissue and emphysema? What's the driving force? So
Very interesting about sleep apnea.
Yeah, that is, I mean, it's so funny because it makes so much sense that if you aren't breathing overnight, your heart and your body's not going to do well. but the mechanisms of kind of understanding that, that's something we should treat and take care of. Yeah.
And so you said the latest thing that you're doing now for sleep apnea, what was that?
So there's patients who have obstructive sleep apnea where the airway kind of collapses, and that typically we use CPAP, which is a positive pressure with a mask that everybody hates or thinks they hate anyway without even trying it, but they won't wear it. I've got a lot of patients that won't even do a sleep study because they know they have it and they don't want to be told to wear a mask. But in some cases that can't be fixed with a CPAP, and then there's a device. It's like a pacemaker for that. In patients with congestive heart failure, they're more prone to actually what's called central sleep apnea, where it's not an airway problem. Their body is not actually stimulating them to breathe like it's supposed to. Their lungs just aren't expanding. The brain's not sending the signal out to breathe. So that device called the Remedy device runs a pacemaker wire down to the diaphragm and stimulates the diaphragm. Instead of through a pacemaker, which is giving small impulses like 1 per second, it gives sustained impulses similar to your normal breathing rate, so that it'll force your muscle to contract and you inhale and exhale when it relaxes. And it's funny, with those biventricular pacemakers, we can actually stimulate the diaphragm accidentally during the procedure, and it's like giving people hiccups. You can see the diaphragm move. So that's sort of an advancement on that notion, that if we can make the diaphragm move in people who aren't breathing because their brain's not telling them to move and expand their chest, then and in those patients, CPAP doesn't really work well. The positive pressure device doesn't do anything if your brain's not telling your lungs to expand. So that's a category of people in particular where the masks and things aren't really a benefit. Putting them on oxygen has been the only thing that has any benefit, but even that's kind of minimal benefit. This device actually has shown improvement in people, and their quality of life gets better, their symptoms get better, some of the heart failure measures we look at gets better, pressure in the lungs, things like that go down. So, it's more and more we're seeing things are going towards using devices to help the heart get better in ways that kind of tinkering with pills unfortunately can't always give us. Yeah, we do electrophysiology, which is the arrhythmia side of things, and classically pacemakers for people who have a slow heart, or defibrillators for people who have high heart rates and arrhythmias that would need to be treated. There's been a lot of overlap because of the number of people with congestive heart failure have sudden cardiac arrest and ventricular arrhythmias that need a defibrillator. And then since I started doing these procedures with the cardiologist at the heart hospital in 2003, was really when we started doing these third wire things, and everyone was sort of like, well, I don't know if that's really going to help a whole lot. And now that's become a main treatment for us. As soon as we can, if we see anybody who's got a widened EKG, we try to get them, on the device, because it just keeps proving over and over that they do well with it. And I joke with some of my heart failure colleagues that they don't ever see those patients come back, so they don't realize how well they do, because they stop going to heart failure clinic because they're doing better. So they, they still see them, but we really see people come back and they feel amazing. It takes time in some cases. Some people feel better the next day. Some people it can take up to a year for it to really start to improve. But
so is there any change in coronary artery disease diagnosis?
In terms of the treatment for congestive heart failure, still the same things. When you have coronary disease, your risk of dying from the ventricular arrhythmias is higher after a heart attack or a stent, unfortunately. So, in that category in particular, we especially use the life vest, the wearable defibrillator, while we're waiting with medicine, because it's not really fair, at least in my opinion, to tell us, so when you're at high risk for dying from this device, but we're going to wait and see if you really do, which is kind of how the guidelines are written, unfortunately. That that they're at high risk, so there might not be a point in putting a defibrillator in if the risk of arrest is really high. So we generally give people a life vest, which is like a wearable defibrillator they take home and wear it at night while they're sleeping. You wear it under your clothes. It's just got a little battery pack. I apologize, I was going to put a picture of that in here too, but it gives you some protection while we're waiting to see how people do with the medicine. Lots of times nowadays, we don't have people have through and through dead heart attacks like on that picture. Or if they do, they're silent heart attacks. Fortunately, with the door-to-balloon things that they do in hospitals and trying to get people either on blood thinners or stents right away, people recover. People get, we have people with 100% blocked arteries that they come in and get them wide open, and they recover heart function, a lot of them, back to normal.
So stents had a bad period of time when they were looked down on. Is it better now?
Yeah, that's our primary way I think we reperfuse people is with stents nowadays. There's been more studies that are looking at, does it affect mortality? If you have somebody put on a stent and somebody you just put on medicine, nitro and aspirin and statins and beta blockers, are the people with the stent going to live any longer? Arguably, they don't necessarily live longer, but quality of life wise, I think people feel that that's better. I think it's hard to walk away from an artery that's 100% blocked or 95% blocked and go, oh, we'll just put you on a pill and see how you do. So.
It's very good, very informative.
Oh, you're welcome.
Thank you.
All right. Well, thank you very much. Thank you.